Yep. So, hi, Anne.
Hi, how are you, Doctor?
Yeah, well, thanks. How can I help?
Oh, look, I normally see your colleague, and I was just here for my script. I have pain, and I'm on endone, and Dr. Black's away, and I usually just see someone here at the practice when he's not here.
Okay. Well, so we're meeting for the first time today. Okay. I'll have a bit more of a look through your notes here. Yes, I can see that that Dr. Black sees you as your main doctor. So, so you're here for some pain medication, and you're here. Sorry, what was the pain medication again?
It's called endone.
Okay, sure. So, no problems. What I just need to do to start with is for you to tell me a bit more about it. So if you want to just tell me, I know some of it's written here, but I just need to know a little bit more about, say, how much you're using and a bit of the history, just in your own words.
Oh, okay. Well, I'm a nurse, and a few years ago I hurt my shoulder transferring patients. I mean, I'm sure you understand how physically demanding that job is.
Sure.
And I've had ongoing pain in my shoulder, and I need to work. The endone is what I use to treat my pain, and I mean, I take it responsibly. I just take it when I need to.
Sure. Okay. Well, look, I imagine that you're aware that there are some very specific guidelines around prescribing endone. So, to that end, and you've been using it for a few years, you say. I just need to know a little bit more about, and you said you had it for a shoulder. You've got a shoulder injury. Can you tell me a little bit about, say, what your pattern of use, like how much you've been using, say, over the last few days or weeks?
Yeah, I mean, I probably use 3 or 4 tablets a day. I mean, when I've got pain, and I mean maybe 5 if I've had a really hard day at work. You know, that can make my shoulder pain worse. You know, it makes the medication makes my shoulder feel better, which makes me feel better, and then I can just, you know, do my job.
Sure. Okay. And do you ever find yourself, what would be the most that you would use?
Oh, I mean, I know my limits. I mean, I don't know. I mean, 5 on a bad day. I mean, I suppose I've had really bad days that I might have taken more, but yeah.
Sure. Okay. And do you take it after work? Do you take it sort of during a regular work day, or when you're sort of on other days?
Oh, look, there have been days that I've had to take it when I'm at work. You know, I wouldn't be able to work, and with so short staff, like I mean, I have to take it. Yeah. But you know, I've been on it.
Yeah.
Sorry.
Has it ever caused you any sort of problems? You know, either at work or outside of work?
Oh, it can make me feel a bit groggy, I suppose, if I take too much. But you know, I've been on it for such a long time. You know, it doesn't really do much for me. I like, it just treats the pain. I'm pretty good, I think.
Okay, and have you ever had troubles with needing to use, say, a lot more, or having trouble cutting down, or feeling unwell when you've stopped it all of a sudden?
Well, I mean, I don't stop it. I mean, that's why I come and see Dr. Black, just gives me my scripts. And I mean, no, why do I need to cut down? I mean, I don't see why I need to stop it. It's working for my shoulder pain.
That's okay. I think we'll look into that, I think, a bit more. And has anyone ever expressed concern about your medication, or is it it's always been fairly standard with Dr. Black?
I mean, Dr. Black and I are good friends. I don't know. No, he's never been concerned, and you know, my husband knows that I take it, and you know, every second nurse at work's got an injury, so no, I don't think so.
And does you said sometimes the medication helps you? Does it help you unwind or help you at the end of the day? Often when people have persistent pain, it does affect their mood. Does that happen to you?
Okay, we're halfway through, ladies.
Life's a bit stressful sometimes, and you know, so I suppose if my shoulder's hurting and I'm feeling stressed, it's all, you know, it all builds up. So if I can take the painkiller that makes me feel better, then, you know, yeah.
Sure. You've never been worried particularly with feeling anxious or depressed?
Oh, look, I've had my share of marital problems, and you know, probably felt low at times. I don't know. I don't think I've ever had depression, but I don't know.
Sure. And so, what are the other? Do you take any other pain medicines? Do you take any long-acting pain medicines, any anti-inflammatories or Panadol?
Oh no, that, you know, the endone works for me, and you know, I suppose I'll take a few Panadol here and there if I have to, but you know, no, just my endone.
And aside from the medications, do you have any other non-medication type management for your shoulder pain? So any other investigations or therapies or sort of plans?
I saw the physio back when it all sort of happened, and had the physio, but it wasn't helping. I did in the end. I mean, I have to keep working, and so I just take painkillers.
Sure. Okay. Look, appreciate your honesty and with all the questions. There are a few issues here that I need to raise, and look, this may all be able to be sorted out, and perhaps with Dr. Black when he comes back. The first thing is there's very specific rules about prescribing those medications and the category, the S8 category of the medication, particularly in the long term. And so usually the rules are about one prescriber only with a designated backup. So because this sits outside of that, I just need to make some double checks.
Okay.
The second thing is that using endone with working and driving raises some safety concerns. And so I know I've met you only the first time today, so I probably need to just make sure I've got all of the information and talk to someone senior, perhaps Dr. Black or somebody else, just to point me in the right direction. But I need to make sure, firstly I need to look after you, but I also need to make sure that you're safe at work, and also endone's a medication that really does affect your driving in terms of risk of crash risk and sedation, and the guidelines sort of point that out. And certainly while we're sort of clearing this up, while we're getting on top of this, I'm very happy to write you, say, a certificate and make a plan to follow up very soon, so that this doesn't have too much of an impact on your work and your income. And I guess that the last thing that I just wanted to, or the last two things, were that endone is a good medication for acute pain, but it's not an effective medication for persistent pain. And I just feel that we might not be treating your pain as well as we could using that one. And I think it's worthwhile exploring other options, because there are parts of the day where endone's wearing off for you, and you're also at risk of a side effect. And just with the last thing, so everybody that has, you know, a persistent pain usually is having their treatment as part of a sort of a holistic plan that includes you know, physical therapies and making sure that the diagnosis is correct. And so I guess if you're my patient or Dr. Black and I share you as a patient, we need to be clear about having a management plan that sounds a bit more like that. Is that okay? How does that sound for you?
Yeah, I mean, I suppose I just feel like I'm in pain and I need painkillers, and yeah.
And so I guess what I hear is that yes, you have unrelieved pain, and I think that perhaps there are lots of opportunities for us to improve that for you and to keep you at work. But I think we need to address some of the serious safety things today.
Right. Okay. Yeah. Sure.
Time. Thanks, ladies. That was good.
Thanks, Alison.
No worries.
So, I suppose everyone, I encourage you to pick some holes in that, but we hope that we've given a kind of an example of what it might look like, and everybody's going to do that station quite differently, and that doesn't necessarily mean also that there's only one way to do it to do it well. So this slide about feedback, just have a read about that. When you're practicing for your exams, you're going to be getting feedback and giving feedback to your colleagues. Just think about how you give your feedback and how you make good on the feedback that you receive. So now, does anybody want to, I suppose Alison or the audience, want to give me some feedback?
I'll start, and anyone that wants to type in some feedbacks in the box. So look, I think what Lisa's done well is this station is designed that this is a patient that's presenting requesting an opiate, and so you know these consultations that I'm sure most of you that have been doing general practice would have seen can go the wrong way if you you know, are obstructive straight out. If you sort of say, well, no, I don't prescribe that. So I think Lisa's done a good job of keeping the patient engaged. Not saying no, but you know, trying to set some reasonable limits in place. the only thing that we didn't get time for, and this is a pretty big consultation. I'd challenge most experienced GPs to get through this in 8 minutes. Is that there is, because this patient was a nurse, there is some issues with medical registration, and so that is something that I imagine Lisa would have gotten to point out to the patient that we need to have a chat about mandatory reporting, which is different in every state.
I think, Alison, that's a really good point, because in my head, I was thinking risks about work, and I had thought that APRA and work, but I hadn't actually articulated that. And because we've been practicing that sort of in front of me, I kind of assumed that I covered it. So that's what happens in the heat of the moment. So sometimes when you're writing notes to yourself, just writing, one word to highlight an issue is enough to keep you on track.
Okay, there's just a couple, I think there's one question and one statement. So Guang, do we need to identify that she's a drug seeker first?
As Alison, I can answer that. So I suppose it's really, I don't think you have to come out and say in the station this patient is drug seeking, because I'm not sure that you actually can. I mean, in this situation, depending on how the patient plays the role, patients have pain. Now, the teaching generally is that if somebody comes to you requesting pain relief, and they're talking about having had pain and it's been going on for a while, particularly if they're the patient of another doctor, I think at the beginning you have to give them the benefit of the doubt. That doesn't mean that you need to prescribe them ridiculous quantities of opiates, or even any opiates, if at the end of the consultation you don't feel that that's an appropriate management plan. But yes, you do need to make it clear within the consult that you're aware, as Lisa's done, that perhaps the prescribing, as Lisa's indicated, that prescribing endone for a number of years is a bit outside the norm for standard management of chronic pain.
So I think it's can I just say something quickly? Yeah. And I know we're limited for time, but I think certainly in the realm of addiction medicine and persistent pain, we would use more we try and reframe words like drug seeker to someone requesting an S8 drug, and someone with a drug dependence problem. And then I think, so someone said, oh, is it okay to prescribe it or not? Well, I think this consultation could go many ways. It's really about safety. So the one option that I was going to give was just to give a short supply and then book an appointment with Dr. Black at his next available day. The issue about who's going to become this patient's regular doctor is part of the discussion. It might not be resolved in the consult, but it can be raised. So I don't think it would be wrong if you gave a short supply, because this does happen in real life, but as long as the issues were raised. And so I guess if someone is, the other thing that you could raise in terms of a drug seeker, so I guess when you're talking about prescription shopping, then it's to say another thing that could be a nice way to explain it in this case would be, it's usual for me when I'm meeting a new patient and prescribing this medicine to check with one of the prescription services about your dispensing. It's routine. Use words like routine, take away blame, and that way you can actually highlight that this person is using different doctors to procure substances of dependence.
And I guess that you've answered the question for Latika here, who asked, so in the end, is it right to prescribe the drug? I think it's been answered that it's probably right to give a smaller prescription, at least until the regular doctor comes back. I'll just hand over back to Lisa now to go through the RACGP marking criteria.
So these are similar, and in some cases, similar template to what the examiners are going to be using. So these, as you can see, cover a lot of the domains. They're listed in, I guess, chronological order, and there's a scale. There's actually a 2- or 3-dimensional scale in some formats that I've been shown that allow an examiner to push a patient from a borderline scale to borderline pass. So I think for this, it's good to become aware of this format, but you don't need to know the detail. I think the thing here is that if you perform a logical, if you have a logical performance, once the examiner's ticked a box, often in the first, say communication and rapport, if you open things nicely and you start your history, they can tick the box and they won't return to it. It makes it easy for them to mark. So think about how logical it is that you proceed through your station. So yeah, so having a look there. So we'll talk about communication. The next one. Oh, sorry, where are we? Yep, diagnosis, problem definition. So just see there as well that diagnosis is only one part. For some cases, the diagnosis may point you in a very different direction, and if you don't get that, you might not be able to achieve the rest of the marks. But just remember, you won't know whether or not that station is being weighted towards the history or towards management in most cases. So just go through and cover it from beginning to end.